So in terms of steroid refractory acute GVHD, I think it's clear to say that for most practitioners, Ruxolitinib is certainly the option that is utilized in that situation. And so that's based on the results of the REACH2 study, which compared Ruxolitinib against best available therapy, which is essentially the other agents that we think about in patients with steroid refractory. So ECP was commonly used. TNF-alpha inhibitors are frequently used. Integrin inhibitors are frequently used. But in this Ruxolitinib study, when Ruxolitinib was compared to best available therapy, certainly it seemed like responses by 1 month were superior with Ruxolitinib, and essentially durability of response was superior as well. But that doesn't mean that all patients, achieved sort of control or improvement of their acute GVH. If you read further into that study, what you see is that there is this emerging population of about a quarter of patients who subsequently required additional therapy. So despite Ruxolitinib administration for steroid refractory, there was still a need for additional immune suppression due to inadequate acute GVH control. So I think that this treatment refractory, which is receiving steroids, receiving Ruxolitinib or another therapy, is going to be a big unmet need going forward. A quarter of patients, who potentially have steroid refractory acute GVH. And so that's why this particular study, now provides some data for a novel agent that potentially addresses that unmet need. And so that's why I think that this is a very interesting study. And one of the first studies I've seen where that was a particular population of focus, which I think will be an increasingly important population going forward.